Thank God it worked.
I'm going to invite up Marcy Pelot. She is one of our interventional nurses. Marcy has a unique perspective working in multiple different endoscopy labs, as well as one of our nurse navigators. She's a wealth of knowledge, and I'm very excited for her talk.
Well, good morning. Thank you for the great introduction. First, to start off, thank you for attending RMIE. This is where I feel that our department shines. We do want to deliver the best care we possibly can for our patients. And I think this really showcases how we can do that. Now, I know there's been a lot of advances over time and a lot of equipment that changes over time, but ultimately the nurse's role is still very similar. It's to support the physician and to support the patient. So with that, we're going to discuss a little bit of CMR or EMR. You can either, do both of these kind of at the same time. So we want to discuss how we're going to take out said polyp. We are going to have several different videos, nothing real exciting or nothing real scary or anything. We're going to discuss the tools, whether it's physical or whether it's just environmental. Also, we're going to want to discuss the risks for our patients and how to manage that after. So here's a short video on a hot snare. You can see they're using a lifting agent, unclear on which one, but it does look like there is some blue there. You'll see in a moment they're going to open the snare, and obviously that entire polyp is not going to fit in that snare. So they're going to do it piecemeal. What's important about this is to make sure that you have a plan for this piecemeal polypectomy. You don't want to leave islands of tissue. So they're starting on the left, and they're using that first cut area to anchor the snare into that and to close. Of course, those submucosal fibers look amazing. There's no muscle in there. Muscle would not show blue. It would be white. And I did borrow some of these slides from one of our doctors, Dr. Bilal, so I cannot take credit for any of the videography on this. Oh, okay. And we stopped. All right, well, we'll just go to the next one. All right, so my question is, how many people do hot snare CMR are familiar with this? Okay, so a fair amount. So we're also going to now go into cold snare, which is basically not using cautery. These can be used for your sessile serrated adenomas, still that needs to be taken out. And here they decided to use a blue lift again to better define the polyp. The polyp will not take up the blue, so it helps define those edges really well. All right, still injecting. And at this point, I'm thinking to myself, is the snare going to slip over the polyp the entire time we're trying to remove it? All right, it looks like here they're starting to open the snare. It looks like they're using a lesion hunter just based on the tip here. It's one of the cold snares on the market. It's pretty sharp, has a nice click to it, so it's very satisfying to cut that polyp off. And again, they're going to use a piecemeal technique to move around and get the edges of the polyp along with a little normal mucosa for better pathology and prevention of reoccurrence later on. And you also notice in this CMR that they are using a cap to help hold down the folds, better to move things around. Also, they'll use it to suction mucosa into the cap to grab a bigger section or bigger piece of mucosa. Again, we're seeing a nice blue submucosal lift there. No white muscle, which is fantastic. And they're still going.
Just look at the celery.
All right, and that's kind of your end result there. Next slide is very short. So what we started doing here a little bit with the addition of Dr. Bilal to our practice is underwater EMR, and you can do this cold or hot. And basically what we're doing is using the weight of the water to help separate the mucosal layer from the muscularis area. So this way you're not having risk of perforation. The things to know when you're the backup or the nurse for this, make sure you have at least 2 or 3 liters of saline on your back table because you will go through all of it. Make sure you also have a lot of suction, whether it's the canisters or whether you're using a Neptune type situation, whatever it is, make sure you are prepared for all of that. So now we've seen a couple of the different techniques. So let's talk about the tools. Now we all know about the physical tools for CMR. You know, we have our snares, we have our cautery, we have our injection needles with lifting agents, we have polyp traps, you know, clips and Puristat and coag restors. We have all of these things, but let's talk a little bit about the mental. Where are you doing your procedure at? Are you in a surgical center? You come, you're doing screening colonoscopy in a surgical center and you find a 4-centimeter polyp. Is this provider have the ability to safely remove this polyp? Because once you start injecting, you are committed to now removing this. So you want to think to yourself, okay, fine. We're 3 hours behind, but it's okay. We're going to take this 4-centimeter polyp out. Can we manage the complications? Do you have the tools to manage the complications? Do you have an Endoscopic type clip to be able to seal a perforation? Do you have regular clips? Do you have a product called maybe something like Puristat or Hemospray to help with bleeding? These are all things to consider as you're looking at this polyp. But also what's most important is the physician looking at the polyp. Now, are they using a cap? Are we going to be able to see the entire polyp? I've been in situations where you look and, oh, it doesn't look so bad. And then all of a sudden you look behind the fold and you're going, oh, that's definitely different. So now we need to consider, are we able to do this? Is this 5 o'clock at night and we still have 3 more procedures to go? These are all things that as a team, we want to make the best choice for the patient as nurses and techs. We have providers here that say, you know what, we don't have time to do this polyp today. Let's reschedule them. That's okay. We would need to make sure that we feel empowered to do what's in the best interest of the patient. So couple of slides on the snares here. Obviously, we have a bunch of different sizes. We have a bunch of different shapes. We have cold, we can have hot. There is even a needle on the market that also has a snare attached to it. We can do that. Your snare is not up for your picking, obviously, but it is up to the provider, making sure that maybe there's that conversation ahead of time. Like for us, we're lucky. We're a referral center. So the community is sending us our patients a lot of times. We're not doing screening colonoscopies and interventional generally. So we can look at the pictures. On the front side, our nurse navigators request the color pictures They request the pathology if there is any. And the physician has all those tools to make the decision. Are we dealing with something with high-grade dysplasia? Is there some maybe center depression or ulceration that maybe a polypectomy is not enough or an EMR is not enough and we need to consider ESD? Usually these patients are seen in clinic first before they even come to us. So we do directed procedures. We're not doing a whole colonoscopy necessarily. We're saying, okay, well, we got a referral for a descending colon polyp at 30 or whatever, or sigmoid, and we're going to go in and we're going to take that off. Then the patient's going to come back in 3 to 6 months. We want to assess our area. We will look at the rest of the colon usually at that point, just to make sure that there is nothing else going on. Then at that point, we send them back to their provider with our recommendations. Another screening colonoscopy in a year. And then depending on number of polyps, where they're at, there's guidelines for that on the physician side. If there's so many tubular villus adenomas, they'll come back at a 5-year period versus a 7 to 10-year period. So as far as the nurse goes in this role, I'm very passionate about making sure my patients are safe. I just want to make sure we're doing the best for them. So we also have now polyp traps. A couple of different kinds in the market. We tend to use the one here. I think it was my no, okay. So the one on the left is the one we have at our department. We've used the other ones throughout my career. I have the multiple channel ones and may have put a couple extra polyps, so the physician may not have been happy with me as I had 2 polyps in this from this different locations in the same container and didn't know which was which. So just be aware of that. Also, we do, when you're doing your hot snare polypectomy, we are using cautery. This is just an example of what we do here. There's no set in stone program or any of that. So don't look at this slide and tell your provider, I was at this course. This is what we should do. That's not necessarily the case. It's going to depend on the type of cautery you have, whether it's an RMIE or something else. Also the age of it. That will determine what different kind of settings you have. Some of the older RMIEs have stuff that's different than the current RMIEs or the newest ones on the market. So just know that that discussion happens before we start cutting. We have the patient grounded. We have the RMIE in the room. What do you want next for your settings? Some of ours are pre-programmed because that's what our providers like. So it's easier for us. But not knowing your other providers or how many different ones you work with, just always verify. Just like opening the stent in the video, verify with the provider. All right. So risks of CMR. Again, on the nurse navigator side, I would get these calls after the procedure. I would try to touch base with all of my patients that I supported for my providers prior to their procedure to prepare them. I would already lay the groundwork prior to the procedure saying, well, we're going to take out this polyp for you. We're going to schedule you on such and such date. Make sure you have a good span of time. Your procedure could be 2 hours long. And bleeding. You might have bleeding afterwards. That's okay. If you take out a cold polyp, you're going to have some bleeding. The problem is, when is it an issue? When is it not? Is it a couple smears on the toilet paper or is it turning that toilet bowl red? That would be an issue. If there's clots in there, again, that would be an issue. What do you tell your patients? Where do they go? Come back to us. Don't go to another hospital. If they're somewhere in Nebraska, still come back to us as long as it is safe to do so. This is where your assessments come in. Are you dizzy? Are you lightheaded? Are you sweaty? Okay, fine. If it's a true emergency, go to your closest hospital. But ideally, I want them back at our hospital. We want to take care of our own complications. That should not go to another provider. Also, afterwards, in this, we're going to talk about maybe considering a softer diet for a couple of days. We don't want anything scraping off our effects of our closure, whether that would be clips, whether that would be a Puristat type of thing or Hemaspray. We want to make sure that we're providing the patients the best opportunity to heal. It's going to take a while. It could take up to a month. So most of the amount of bleeding is going to be in the first 2 weeks, but it could be up to a month, especially when we're looking at our 7 or 8 centimeter large ESDs. Also, we're going to talk about NSAID use. Also on that, on blood thinners, there's a ton of them on the market. You know, it's not up to us. It's up to us to prepare the patient. So we want to make sure we're preparing the patient like, okay, afterwards, we're probably going to hold your, Plavix, whatever, for a day. Maybe they're working with a provider and they say, you know what, it's okay. Why don't we just put you on aspirin in that bridge period? Maybe they'll do a Lovenox bridge. We do have a pre-procedure services clinic here. Sometimes we'll send them through, but a lot of times we're going to be having the patient speak to their prescribing provider on that. We don't make those calls here. They know the patients better with the risk, and we want to provide that information from their provider, so their provider also knows that they're going to follow those instructions. Perforation, obviously, we talked a little bit about that and about how we are going to make sure we have the tools on hand if we can. We have been in situations where it's late at night, we're doing a procedure, we pull back the scope and we're like, oh, now we're seeing fat globules and we have a perforation. What do you do? Remain calm. That's the first thing you can do. Ask the provider. Okay, well, it looks like we have a perf. How do we want to handle this? How big is it? In my mind, I'm already assessing this going, it's too big. It's 3 centimeters. We can't use an Endoscopic possibly on that. Maybe we have suturing. There's a couple of different suturing tools on the market. There's like NXT, there's your standard like first gen Apollo stuff, and I forget the name of the third one that we have here. Some of them we can use with a regular EGD scope. Saves time. Setup's a little cumbersome though. In the setup, you also want to make sure that you know what you're doing. Do you have the tools mentally also to know what you're doing? I have been in a situation where we have called the rep. Okay, we're in this situation. I FaceTime them. Can you look at this and make sure I'm good? I think I know what I'm doing, but I want to make sure also, and that's okay. I am okay with my limits and telling the provider, okay, I think I've got this, but let me double check. Communication is your biggest tool in your tool bag for any endoscopy procedure. Also, we want to talk about recurrence and incomplete resection. Since we are a referral center, we come across polyps where the doctor has worked on it 3, 4, 5 times. And now we're like, oh, how do we take this out? We are very lucky here to have providers that will do a full thickness resection, where we basically are taking a cap and bringing up the muscle and the mucosal layer all within that cap. And then we take everything off, send to pathology, hopefully get clear margins. If we do not get clear margins after that, they're probably looking at surgery. Reoccurrence. How to prevent that? Your providers, I'm sure as you guys have seen with other CMRs and as you're going on in your progress, they'll kind of APC or they'll just burn the edges of the polyp. That is shown to decrease reoccurrence at that site quite significantly. And since colonoscopy still remains one of the best ways to prevent colon cancer and removing polyps, to add to that, this is so important just for patients moving on, and especially now that we're seeing polyps and cancers starting to occur in younger patients. I mean, I don't know what you guys are seeing in the community, but here we're seeing 35, 40-year-olds with colon cancers. And at this point, they're now metastatic. So we're not managing a polyp at this time. We are now managing the complications from that metastatic disease. So it's just something that I'm very passionate of making sure that people know how to do this, when to do this, being safe to do this. And I think that is kind of where we're at. Any questions about anything? Did I go too fast?
I have a question. Can you talk a little bit more about lifting agents, why we use them, and then just kind of the different layers and how that, yeah.
So we use 2 different types of lifting agents here at UC Health. We do have an Everlift. I don't know what company that comes from, but it's already got glue in it. And sometimes we'll even add like a half a cc of epi to it for lifting. to help with bleeding. We also have Endoclot. That's where it's a higher viscous or kind of like a potato starch, and it comes in a dried powder. You mix a little bit of saline in there. We'll add a couple of drops of meth blue, but we'll also add epi to that as well. So this way you're having more of a sustained lift on that polyp to buy you some time. Yes.
I know the answer, but do you ever run into situations where you and the doctors have decided that you're going to go through to follow through and resect this, and then you've had to stop and you weren't able to resect? What are the reasons maybe you've had to stop?
Yeah, absolutely. This is definitely one of those situations where it could be a couple of reasons. Is this invasive? You know, you look at the polyp, there might be ulcer, but is that an ulcer from maybe a previous biopsy from their screening colon? Or is this deeper invasion into the muscularis? And if it's not lifting, maybe we shouldn't touch it with a CMR. Maybe they need an ESD. We have gotten into those situations where the pictures, they look fine, looks removable. We've gotten the pathology. It's only high-grade dysplasia. Where did they biopsy on that polyp? They go to the center? Did they go to the edge? They go behind it? That dysplasia goes from high grade to cancer, and it kind of goes in the center, but that also doesn't give you a read. Pathology is a little rough. You know, you get these cells in there and it may be inflammatory, and it's hard to tell the difference sometimes between the inflammatory and the adeno. So we just want to make sure that as we're lifting that, oh God, I'm going to probably talk really loud. As we're lifting, we're making sure that we're looking at the whole polyp. Again, this is coming with the assessment. I will always chime in to my physician and say, it's not lifting over there. What are you thinking? Again, it's not up to me how we take that polyp out or when to take that out, but it is my job to say, are we sure about this? Because this is what I care about. I care about our patients and their safety. I don't want to cut something and then all of a sudden we now have a perforation. Polyp's still there. Now we still have a perforation. Now they're getting surgery. And I would like to prevent that at all costs. Hi.
Hi, Marcy.
Hi, Jen. We've spoken a lot over the years.
You guys are so great, so I'm grateful that we have you as a resource. So you hit on a little bit getting an EMR. You got the pictures, turns into an ESD. Before the case, what goes into deciding case lengths? Is that a navigator? Is that a doctor? How does that function?
Yeah, that usually comes from our providers. So what we utilize here is just like a little cheat sheet. It's called like a high-tech worksheet. It's just a little communication tool between the provider and the staff that are doing the procedure. They'll usually do that at the clinic level, or they'll tell their navigator like, hey, I'm gonna need 3 hours for this. I'm gonna need 6 hours. We've done them for 8 hours. So they're going to need a little bit more time. So it's kind of all through the process. Now I get that referral in, I'm looking at it, I'm like, okay, that looks like a 2-hour one. So in my mind, I'm already prepping myself how to prepare the patient. After they're seen in clinic, it might change and like, oh yeah, we're going to need 3. So that's fine. That's no problem. So fortunately, it's not up to me, but the hard part is when we do get in there, we only book for 2 hours and it's going to take us 4. Everyone will now be delayed and we're not going to rush. That's not fair to anyone.
Awesome. Thank you.
Yes.
Can you explain the difference between a CMR, EMR, and ESD?
So CMR, EMR, ESD. CMR is colonoscopy, you know, like mucosal resection. EMR is just endoscopic. They're kind of used interchangeable, but endoscopic, I think more like the upper part. And then ESD is endoscopic submucosal dissection. So that's where we're doing the layers of the polyp and we're tunneling underneath, almost like a poem if you've ever seen one. And we're wanting to stay a little bit closer to the polyp and less close to the muscle. Again, we want to avoid the muscle to avoid any perforation.
With EMRs, you're snare. Did everyone hear that? So I was just pointing out that the tools are very different for an EMR, CMR as opposed to an ESD, because the ESD, you're more using a knife and slowly like dissecting under it, whereas with EMR, you're just taking a stare and kind of grasping the whole thing and pulling it off.
And also your Irby settings are going to be completely different. You could be using like an Irby jet where you're constantly able to flush and lift in there. And we may be switching out between endoclot and just saline. Just depends at what it needs at that area. You know, the edges tend to be pretty safe. You know, we're getting good lift and then all of a sudden we start tunneling for that ESD. Now we're running into more scar issues. So now you're looking at, okay, we might need more lift, the endoclot lift versus just the saline. Using a cap to be able to pull stuff up. There's also some products on the market to create like a tension, to kind of lift that polyp up and create more of that space. Anything else? All right, well, thank you. I hope you guys enjoy the rest of this course.